So why do the waveforms all look, why do they look different sometimes? So when you look at any kind of textbook, you're gonna see this kind of waveform here, but you never really see that on the ventilator. You can program that into the way that the volume is delivered to the patient, but usually we have to do a maneuver to get this waveform to look like this. Usually the waveform just stops right here and comes right back down to baseline. This little plateau here is the plateau pressure, right? And to get that plateau pressure, we have to do what's called an inspiratory hold. All right, so it's a special maneuver we do to assess the pressures in the lungs, right? We always get PIPs. We're always going to be able to get a PIP on a patient. So as we deliver 400 cc's, let's say, right, we're going to get, with no holds, we're going to be able to get a PIP, right? And it comes back down to normal. And then we ventilate them again, and it's going to hit that PIP no matter what, but we hit the little inspiratory hold button right there, right? And then it comes back down to normal. So we are able to see and measure our plateau pressure in that situation. We always get PIPs, 30, 35, 28, 25. We always get PIPs measured, right? But if we want to know what's going on, if they have a effusion on this side, or they have a pneumonia on that side, or they have pulmonary edema filling up, we got to figure out, or they got obesity right here, right? What's going on? So we can say, is it a compliance issue? Is there an inability of the lungs to expand? Inability of the lungs to comply, right? And that's the situation right here, these red arrows. The lung it has poor compliance, right? The PIPs are going to be high because it's difficult to get that 400 cc's in them. Because why is it so hard? Well, was it a neck problem, right? At the top here, was there a neck problem? Or was it a compliance problem? Okay, so we can tell the difference. So we know the PIPs are going to be high, but we can say, with the once I get all that volume inside the patient, that everything was like peachy keen, and it was like, whoa, that's great. There's so much, the pressure is actually pretty low. That means I had a really high PIP initially, right? And that means it was a bronchospasm issue, or a kinking issue, or a secretions issue. Whereas if the plateau pressure was like higher up here, a little higher, see here, this one's a little higher, the difference right there, that means there is a compliance issue, right? The magic number is like 5 to 10. So if it's a difference of 10 or more, the PIP versus plats, it's a bronchospasm or a upper airway issue. If it's less than 10, it's probably a plateau issue. Okay, so this inspiratory hold is where we just press the little button and it automatically holds for us. You get a little waveform. On this vent right here, the servo at the bottom left, the numbers pops up for you. On the $40,000 Drager machine, it doesn't. It's like, why can't you get this? Why that should be your one and only thing. That's the most common maneuver we ever do. And you just hit freeze in the machine, you dial the knob over to be able to measure your waveform. So there's a little more tricks to do for the Drager, unfortunately. Okay, so these are measuring your intrathoracic pressures, right? So the PIPs are measured all the time, and we got to figure out, was it an issue with with the upper airway, or is it a lower airway compliance issue? Right? PEEP is something we're going to be cognizant of, because as the more PEEP you give a patient, the higher the pressures in the lungs will happen, right? Instead of starting at 5, we're going to start at 10. Obviously, that's going to raise the pressures in the lungs. And then plateau pressures, as we mentioned, those are going to be, those can be elevated when you have a compliance issue, okay? And driving pressures we'll touch base on. Okay, so these waveforms here, usually you're going to see just the purple waveform here, but you can hit the inspiratory hold button to be able to look at the plateau pressure and see, is it an upper airway problem? Do I need breathing treatments? Or is the patient biting? Do I need like a bite block? Or do I need to like change the HME on the ventilator tubing because it's causing my pressure to be high? Or is the ET tube too narrow, like 6.5, and maybe they have crusties inside and we need to change it to a 7.0? Or is it a patient that needs diuresis to get some of this fluid out of the patient, or more antibiotics, and they're going to improve from day 1 to day 2? All right, so pressure waveforms. This is a summary slide of all the different pressure waveforms. So you refer back to this guy, so kind of color-coded here. So in orange, you got the PIPs. In red, we got the plats. Which one's more dangerous? Probably the plats getting higher and higher and higher. That's why I kind of put it in red. But PIPs and plats, less than 30. That's where you want it. All right, so if that's less than 30, usually not going to cause barotrauma. All right, so PIPs less than 30. So PIPs is, again, an upper airway problem. So if we look at this little diagram right here, here's normal lungs, okay? And if we have a resistance problem, that's the upper airways that are resisted, There's a problem getting the air into the lungs themselves. Whereas if I have a plateau pressure that's elevated, that's a difficulty with the compliance. The lungs cannot expand, right? So my plateau pressures, oh, my PIPs are going to go up too, but the problem was a inability of the lungs to expand. It wasn't an upper airway problem, it was a lower airway problem. Okay, so when we have PIPs that are elevated, it's either a patient problem or a ventilator problem. So the patient is biting, there is mucus, there's plugging happening, or it's a ventilator problem. The HME is all full of secretions, the ballard is full of pulmonary edema, there's a kink in the tubing, there's a pooling of secretions. There's an obstruction in the way. Also, if you think of patient problem as well, there's a lot of secretions, there's bronchospasm. These are things that are making it difficult for air to get to the lungs in the first place. So it's a upper airway problem when I give that tidal volume, right? And then plateau pressures, we have a failure to deliver, the tidal volume is trying to be delivered, but when it goes into the lungs, it can't expand the lungs. And when you go in there, try to expand, and it can't. So obviously the pressure is going to increase, right? So the plateau pressure is again done with the inspiratory hold maneuver, and you can see that. So this plateau is 7, this plateau is 37. Obviously, this is a much bigger problem. So it's 45 and 7, that's a huge difference, right? We say greater than 10 is usually a problem with we'll tell you if it's an upper airway or lower airway problem. Okay, so yeah, so why would they have difficulty expanding the lungs? It could be the lungs just can't expand, there's pleural effusions the way, there's edema, the abdomen is big with ascites or obesity, the lung size is small with like a pneumothorax, right? One lung is accepting 400 cc's versus 2 lungs, right? One lung is going to be getting a lot of much more pressure and stress compared to 2 lungs. Or they got atelectasis, they got a right mainstem intubation. Like, hey, why I just intubated them? Why the peak pressure is like 45? Well, maybe they're in the right mainstem. Okay, or difficulty expanding in the airways in of themselves, right? You have pulmonary fibrosis, interstitial lung disease, ARDS. All these things are going to cause the plateau pressures to rise, right? So in this patient over here on the right, you can see 45 and 37. That's a difference of less than 10. So they have a plateau problem issue. They have an issue with one of these things over here. The lungs cannot expand for some reason. And simply sitting the patient up might even fix the problem. Okay, so the difference between the PIPs and the plats will tell you. It's greater than 10, that's a upper airway problem. Okay, and then if it's less than 10, that is a lower airway problem, right? So you can see here there's a normal waveform here, I think, right? And here we have a resistance problem. We're getting the air into the lungs, but it's really hard to get up in the upper airways. Look how big that difference is, right? So it's the upper airways that are at fault, compared to this patient on the right that has a compliance problem. The difference is very, very little, right, compared to the guy over here. Okay, so it's difficult. So once the air got into the upper airways just fine, but it hit a roadblock with really, really fibrosed lungs, for instance, and it's difficult for that air to expand, and therefore we have a plateau problem. Okay, so you can look at the peak pressure. If it's decreased, that's a problem too. Right? We've been talking about increased pressures the whole time, but if it's decreased, that means that you have it's super easy for the air to get into the lungs. Well, maybe it's not even hit the lungs. Maybe it's just going right out. You have a disconnected vent. You have a cuff leak. You have a disconnect of some sort, right? That's usually what's going on. You have an air leak. You could have like a bronchopleural fistula where it just goes through the lungs, through the bronchus, out the chest tube, right? That could be the reason why you have a decreased pressure. And then we have, the peak pressures aren't high, but your patient is hypoxic. Well, it's probably not a lung issue. It's probably a PE, for instance, right? They have a pulmonary embolism. That could be the reason why they're so hypoxic right now. And then we have what we've been talking about. So they have an increased pressure here, increased PIP pressures. They need to do a little inspiratory hold maneuver. And you say, well, are they almost the same, less than 10? That's a compliance issue, right? They maybe need diuretics. They may need thoracentesis, or they may need like positioning. And then if it's a super, super wide difference, that's an upper airway problem. They might have a bronchospasm, right? They have an upper airway problem. And then other pressures, we talk about PEEPs, and then mean airway pressures we'll talk about coming up. And what about low pressures? We said were bad. Obviously, there's probably a disconnect of some sort. Again, if your pressures are all good, but you're really, really desaturating and hypoxic, probably might be a PE that's going on. There's something else at work. Okay, so what's the magic number? You want your pips and plas less than what?
Hva det forteste du har syklet før, da?
30.
30 hva da?
30 speed, that's how low you want it, okay? All right, so let's finish this slide. We'll take a quick break as well. So auto peeping. So this is where you're gas trapping. We kind of introduced this to when we talk about end tidal CO2s, where the trend on the baseline is going up and up and up. Should you have a baseline that's more than 0? No. Okay. And this is dangerous because the air can come into the chest, but it can't get back out. Right? So this air traps inside, and it's going to cause, you can't get rid of CO2, and you probably can't get a lot more air that's oxygenated inside the patient. But the other problem is that you are going to get a breath stacking. All right, so here you see the breath stacking. We're trying to stack breath, stack breath, stack breath, and the pressure inside the chest is going up and up and up with each one of those 200 cc's, 400 cc volumes. Those are stacking, 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 and it's going to cause a dramatic increase in intrathoracic pressures, not only causing like a pneumothorax, but can also cause a drop in your blood pressure. Okay, so that's the problem with auto peeping, and this usually happens with fast rates. That's why usually we say don't let the rate go any higher than 35. So because too higher than 35, you start getting risk of air trapping. The other reason this happens with asthmatics. That's usually why we try to avoid intubating asthmatics at any possible point, because it can cause profound bronchospasm. The air can get in, but the air is trapped because they're bronchospasmed up top. Okay. A narrow tube can do it, secretions can do it, where you're able to deliver air into the patient, but it can't exit the patient. Okay. COPDers have this problem where they are breathing, they like to inhale, and they do that little pursed lip breathing, and they want to exhale nice and long, right? Instead of 1 to 2 like us, they like to breathe 1 to 3. So they inhale for 1 and they exhale for 3 seconds to keep those lower airways open at all times and provide that little positive air pressure, and that's what they like. So when they're used to that, they're going to start fighting the ventilator, and they're starting to get some ventilator desynchrony. Okay, so that's the problem that happens with a patient that has auto peeping. Okay, so that's the idea behind auto peep, right? And the consequences of that again are they could get barotrauma and pneumothorax, or what's called ventilator-induced lung injury. And they can also have these increased pressures in the chest, which reduce venous return, blood pressure, etc. And it's more work for them to bring in the next breath, because they're breathing, it's easy for the first 5 to 10 breaths, but they're trapping this air, and it's really hard to deliver this oxygen. So how do you know someone's having it? We can look at the end tidal waveform going up, air trapping. Also, you can look at the baseline here. We're not returning, the volume's not returning back to baseline. The flow is really the only time we're really kind of pointing out flow is not coming back to baseline as well. Okay. So how do you fix it? So an expiratory hold is how you find it, all right? So we can say, hey, stop doing expiratory hold. We're going to pause it. As soon as that volume is done, we're going to pause it. And is there any air left in the chest? Because the only air left in the chest should be what my PEEP is. If I set a PEEP of 5 or 10, that's how much should be there. If there's more than that, right, it's greater than 5 of what my PEEP is. So if I set a PEEP of 5 and it's like more than 10, let's say, that's 5 plus the PEEP, then that's going to be definition of auto peeping. So that's called an expiratory hold. So you have inspiratory hold we talked about, there's an expiratory hold. And the RT can do that. You can say, hey, we're not getting back to baseline on my waveform. So here I got baseline, here I don't, right? I got air trapping here, a lot of air trapping there, right? So that's a sign of auto peeping, and it can cause the patient to be in a lot of distress. The sats can drop, the blood pressure can drop. These are problems that we can hopefully try to address. And how do we do it? Bronchospasm, we can bronchodilate. If they have a lot of secretions, we can unsecretion them. We can do, there's like the devices themselves can be clogged, so we could try to fix those. On the settings on the ventilator, we can prolong the E time. So instead of 1 to 2, right, or 1 to 1 even, they can go to 1 to 3. Let them exhale completely, exhale the whole volume. So it gives them more time to get rid of that air, okay, unless there's less air trapping. The tidal volume can be decreased, so they're not, you take in, it's much harder to air trap with 200 than 400 cc's, for instance. 200 is a little bit low, maybe 250, 300. All right, and then PEEP can be reduced, so that's, we can, instead of going all the way up here with air trapping, let's bring it down a little bit. Let's bring the PEEP down some. And then, if in doubt, you can disconnect from the ventilator to exhale completely, but it's not always the best maneuver because sometimes they were recruiting all that alveoli for the last hour or two, and now it's going to take another 30 minutes to an hour to recruit all the alveoli they had beforehand. Okay, so that's the idea behind auto peeping. Okay, and again, you can always use a breathing treatment.
For a Secret Santa, my boss's daughter got me this puffer holder that hooks to my keys, and it says it ain't easy being wheezy. This shit is gold.
All right, so IE times. So we talked about you could change IE times for someone who has auto peeping. So how do you fix IE times and auto peeping?
You allow for more expiration.
Yeah, allow for more expiration to exhale more tidal volume, right? That's one of the strategies we can do to fix IE time. Again, normal IE ratio is 1 to 2, all right? So you inhale for 1 and exhale for 2 parts. If it's 1 second, 2 seconds, that's a rate of 20, right? So 1 second plus 2 seconds is 3 seconds, times 20 is 1 minute, right? That's 20 breaths per minute. And again, on our ventilator, we can change 20 to 12 to 24. We can change it around and it will change that ratio, whatever that fraction is, right? So that's a normal, that's if you're doing 20 breaths per minute as a cycle, right? But we can change that cycle. We can make it 1 to 3. We can make it, but if you do 1 to 3 for 20 breaths a minute, that's very, very little I time, right? You're not getting a lot of inspiration. So that's, the risk of doing that is you can drop your oxygen and you can drop the amount of volume that you're exhaling, right? If you imagine if you were once doing 1 to 2 and now you're doing 1 to 3, you have more exhalation. Well, I'm exhaling more CO2, but no, really, the volume you're getting rid of is not that much, right? Your E time is being expounded upon, right? It's being extracted. What's another word? It's being elongated. I'm on an alliteration kick. Anyways, we got all these different things that, COPD patients do like 1 to 3, even 1 to 4. They like to have that long E time, especially if they're more advanced, right? If the E time is too short, right? So 1 to 1, let's say, or 1 to 1.5, they can start getting the breath stacking. And the way to fix that is to prolong that E time for them. And they get hypercapnia if they can't, if the E time is too short because they're not able to, catch their breath and exhale it completely. Whereas the E time is too long, right? They have it's 1 to 4, 1 to 3. You're not getting rid of a lot of CO2, right? There's also O2 in here as well, right? So they can also get hypoxic. They can get decreased tidal volume and minute ventilation. You can start getting hypoxic if you start getting less and less volume. Even that volume is enriched with 100% P10. It's still it's still less volume than it was if it was 1 to 2, right? So that's the danger that we keep track of, is make sure the sats are good, make sure we're not having breath stacking, etc. Okay, when you start getting to ARDS territory, which we can go to in the next section, is we have refractory hypoxemia. What does refractory mean?
It just won't go away.
Yeah, it won't go away. So like refractory pain is pain that's still there after pain medication. So it's hypoxemia that's still there after doing all the tricks. We raise the PEEP, we raise the FiO2. What other things can I add to my tool bag? So this is what we can do here, right? We can increase what's called mean, not arterial, but mean airway pressure. So this 1, 2, 3, 4, 5 here in the corner here, these are all the things we can do to increase someone's hypoxia. Sorry, to fix someone's hypoxia, right? Before we talk about that though, but the IE time can do it, right? If we make this 3, we fill that in, make that black, let's say, that's more O2, right? That's more inspired O2, but this is more oxygen you're exposing to the patient, right? So we can increase this I time right here. We can make that more inspiration time. And ARDS, we even flip the script. Instead of doing 1 to 2, 1 to 3, we do inspiratory time of 3 seconds and E time of like 1 second, right? Or let's say 3 to 1 ratio, let's say. All right, so you can split that. We can do 1 to 1 first, then you might do 2 to 1, 3 to 1, which is very abnormal. If you try it right now, go, it doesn't sound right, right? You're gonna freak out, right? That's why having a little pressure X on board, or and then maybe even you do paralyzing. You do because it's not a comfortable situation. Comparing to inhale, It feels a lot easier to have a longer exhalation time than inhalation time. But when you want to expose them to more oxygen, we can increase this number 3 here, lengthen the I time. Okay, more air in the chest, that's more exposure to air, right? That's just area under the curve here. That more area under the curve, the more exposure to oxygen. And, you know, yes, there's PEEP, because we can raise PEEP, right? That's number 4 here. Let's raise the PEEP. That's more area under the curve. That's more exposure to oxygen at all times, right? And then what else, what happens when you start doing this? Again, it's not comfortable. It's very comfortable. They can start getting gas trapping. You know, right then, I thought I was going into auto PEEP mode, right, when I was doing that, right? I was like, I just like slow down my respirations, you know, take me off the vent, right? So that would be, you know, that's a risk, but also you're increasing the pressures in the chest when you're increasing these airway pressures, because they are airway pressures. The mean airway pressure, instead of being, let's say 15, is 20. That's more pressure inside the chest, and again, that can affect our hemodynamics. But besides flipping the IE time and increasing the PEEP to improve mean airway pressure, we can increase the flow. So usually the flow is like upright, right? Like you mentioned. If it's not, let's go ahead and make that nice and upright. Like number 1, let's increase the flow, right? Let's make that nice and straight up and down, okay? And then what else can we do? We increase the flow. We can increase the peak pressure. So instead of going to, you know, the volume might cut out at 300 cc's because our peak pressure is set to 35. Let's make the limit 40 or 45 so we get more volume. That'll allow this volume to have more, you know, more effect, more impact, but up to a certain point. So we'll allow it to be a little bit higher. And then I time, E time we talked about, PEEP we talked about, all right? And then the rate, right? So instead of happening, you know, once, twice, let's increase that rate so we have more exposure to more oxygen. All right, so these are things we can do to improve someone with ARDS and refractory hypoxemia. All right, so here's the peak pressures there. All right, so yeah, so what a mode that does this is called APRV, and no one uses it, but it's a great mode because it will, you know, it will actually do all these things. It raises the airway pressure so much that it will, you know, again, it's not to the point where it's causing problems, but it will allow more exposure to someone who's hypoxic. It increases the I time, it decreases E time, it maintains optimal pressures all the way to the top, so they're always up here, and they have very little time in this little valley where we're losing out on oxygenation.
Is that the move you use for when One Legacy comes?
Yeah, One Legacy likes to use it, so often used with One Legacy. One Legacy likes to use it just because they want to show off, but it's actually not great for brain dead patients or patients that are paralyzed. It's great for patients that are coming off paralytics. When you're weaning off paralytics, we want them to have little tiny little breaths, little cute little baby breaths. All right, that's not a flower. You know, cute little baby breaths out on top of their normal cycle. Okay, so what they're doing is they are exposing the patient to all this airway pressure, right, and letting the time that they are not exposed to it be very, very, very little. Okay, so this time they're at the high, right, at the time they have they achieve this high and they're at that high level is about like 4 to 6 seconds, right? So 4 to 6 seconds, they're all the way up there. Can you imagine you're all up there 6 seconds, and then you let go, and then it goes all the way back up again, because the time that they're going to let them down there is like half a second, right? So they'll breathe about 6 seconds up top, 0.6 seconds down below, and they're always maintaining this high pressure and being exposed to all this oxygen-enriched volume. You know, hopefully not too much because it can cause some free radicals, but getting exposed as much as possible. Okay, so it's, you know, there's 2 things they look at. There's T high, T low, and P high, P low. What, you know, how much time are they up top, and how high do you want to go? You want to go to 30, 35, and how low do you want to go? Right? Do you want to, you know, go to 10, 15? You want to go all the way down to 5? Well, this difference should not be that much. It's like the corridor example. You don't want to be opening and closing your alveoli and causing atelectic trauma. So that's called those are called your driving pressures. So you want to keep that usually like less than 15. Okay, so it's great for improving oxygenation, and it can also improve your ventilation. Right, you can have bigger tidal volumes. Right, you're definitely blowing off a lot more CO2. You would think, oh no, they're air trapping, they're not be able to get rid of that much, but you can actually blow off a lot of CO2 as well. Okay, so we can adjust the settings. We're not going to get too in the weeds with this one because it's not used as much, but you can refer back to this. This has, you know, all the information you need for a patient that is an APRV, right? Basically, you set a high pressure and a low pressure, and you set a high time and a low time. and we're trying to expose them as much as possible to this volume and exhale as much of this volume as possible. All right, so recap, right? So we got pressure control and APRV over here, right? So these guys are our sick patients. PRVC is where we usually start, and we're moving over to these patients if we're getting sicker with high PIPs and plats. All right, volume control ventilation is where you set the volume. We can do an inspiratory hold to measure the what? Good, plateau pressure. All right, the PIP is always the PIP. It's always be measured. All right, but the plat, sometimes you have to hit an inspiratory hold. Sometimes they'll program into the breath itself. It's a little uncomfortable. All right. So if the patient's getting better on this PRVC mode, then we're going to a weaning mode. And we'll talk about that probably next time. But now we're getting a little more pessimistic. We're going to be talking about a patient that's getting worse, going to ARDS, right? So how do you know they're getting worse? Their PIPs and plats are going up, right? And we kind of talked about all these modes. And again, Draeger has his own little VC-AC auto flow assist. That's what they call their PRVC modes. All right. So before we talk about ARDS, how else do you know someone's PIPs and plats are going up? We used to spend a lot of time talking about pressure volume loops and flow volume loops, but they don't have as much utility as just looking at the actual pressure. So, because usually we have PRVC now, and PRVC doesn't usually have this problem because it's so intelligent that it knows that, you know, hey, that's way too high of a volume. I'm going to adjust it. So you don't usually see this beaking effect until you have someone like on CMV or AC mode. It tells you when you see this little you know, your football should be looking like this, right? When you start seeing beaking at the top there, right here, that's a sign that your volume's too high. Instead of it's like 550 instead of 500. That happens because it's like squeezing all the extra air into the alveoli, and it can cause some damage. So that's why it used to be a big thing to monitor it, but everybody should be on PRVC now, and that shouldn't be a big problem. But you can see your football kind of falling over like this as your pressures start going high. And it makes sense if you look at what this is measuring. It's measuring your tidal volume, and it's measuring your peak pressures. And here's pressure on this axis right here, right? So instead of being pressure of 20, it's a pressure of 30. The volume is still the same because we're trying to get a good volume. And then you also see your volume. So this is my volume over here, right? My volume is going to start going down as my pressures start getting higher. All right, so PRVC, you set a top pressure, and pressure control, you see this as well. So pressure control and PRVC, you see this as well, right? So you see this, what's called a falling football. So your football should never be deflated, and it should never be falling. Those are signs that you're not getting adequate volumes because their pressures are going up. Okay, so that's the idea behind these guys.